starting to Photoshop Kevin into this picture since he is home with the flu, and we have told him to drink lots of chicken soup and hot tea and feel better soon. He probably feels worse than Layla does in this picture right now. And I can even advance my own slides. So to start with, the non-competing continuation is an annual process for HRSA grants, and it's a way for grantees to update HRSA on your programs and your activities and apply for the next year of funding under the 3-year project period of the Flex grant. So we're going to go through what the NCC is, how you access it, what components need to go into that package that you submit into EHB, budget future reporting requirements under the Flex grant, and then Yvonne will give us a closer look at some of the adjustments to MBQIP in the next report year, and we'll have plenty of time for people's questions. So please do enter your questions in the chat box as we're going along, and then at the end we will also open up the phone lines for more questions. So I don't want to miss any questions people have. To start with, I do want to emphasize that overall we're still operating as the competing grant application from last year. There's a few tweaks to MBQIP, but most of the terms and conditions of the Flex program really remain the same. The EMS funding limit is the same at 25%. And the rest of the project areas are also the same. Repeat what I said before. The non-competing continuation is a progress report and performance narrative that updates HRSA about what you've done, so your past activities over the last year since the award in September, what you expect to do for the rest of this budget year, and then the project plans for next year with the new award. It's an opportunity to readjust and refine the focus of your Flex activities, but we're all operating under the big picture that was established in the Flex application from last year. If you haven't completed an NCC before, or even if you have, do please look at the HRSA NCC User Guide for Grantees. It's on the HRSA Manager Grant webpage on the main HRSA.gov website, and we'll also send out a direct link to that HRSA guidance document on the Flex Coordinator's mailing list. It has screenshots and walks through how to access the components of the NCC in the EHB system, how to fill in the questions, and how to upload files. So it has lots of details into questions. Your NCC is an EHB product, as I mentioned before. That's the HRSA electronic handbooks. Everyone should have gotten an automatic email from EHB on March 15th informing you that the NCC was available in the system. You'll need to be an EHB, both registered as an EHB user and registered to your specific Flex grant in order to access that NCC. So if you are a new Flex coordinator, do make sure you have access and work with your EHB people in your organization to update your access and privileges if necessary. If you have any questions with that, reach out to your project officer, because if you can't get to your NCC, you can't complete it. basic components of the NCC are the SFPPR, which is the Standard Form Performance Progress Report, I believe. It's a automatic form in EHB. You'll fill it out online. The performance narrative is in the narrative format is what you've done. That this is your opportunity to describe your grant activities, your plans, and I'll go into more detail later about what needs to be in the narrative. Again, that's in a narrative format. Then you'll have the work plan from your FY15 work plan updated with current activities and changes, your FY16 work plan next year, a budget justification narrative to provide details on how grant funds are going to be used, and then there's 3 more attachments that you'll include if necessary, which is position descriptions for any new staff, CVs for any new staff, and MBQIP waiver requests if you have hospitals, if you have CAHs that are not currently reporting MBQIP data. Yvonne will go into a lot more detail about the components of the MBQIP waiver later in this presentation. So, some more details on the NCC components. That PPR form is part of EHB and it's pre-populated, but it can be edited if you see errors or changes. The HRSA grantee guidance, the HRSA grantee user guide provides screenshots of all the different parts of the PPR form. Your performance narrative will be an attachment uploaded into EHB as you're used to. So will the 2 work plans and the budget justification narrative. The performance narrative has a 15-page limit. There is no page limit on the work plans or the budget justifications. And then one other thing I wanted to really emphasize is to be sure to request your full award amount, which is the same amount of grant funds as Flex grants were awarded this year, not the amount that you originally applied for, but the amount that you were awarded in September this year. We don't have a budget yet, so the amount of the award we don't guaranteed, but we want you to base your application on the same amount as this current grant year. That should also be listed on your NOA in box 13 where it says recommended future support. And if there's any questions about your budget amount, please do contact your project officer. Diving in a little more, the performance progress report is basic information about your organization, and it's the cover page. Again, most of this will be pre-populated by EHB, but you can edit it if there's any errors or changes. And pages 13 through 28 of the NCC Progress Report User Guide for Grantees, as it says on this slide, provide screenshots and details about how to access that PPR. So more details on the performance narrative. First, there is actually a typo on this slide. Sorry about that. We will send out a correction. The first bullet really should say 12-point font times New Roman and 1-inch margins, and noting that the narrative may be single-spaced. Please try to format it so that it's easy to read. The performance narrative is limited to 15 pages, however, and there's more details about how to upload that document in the user guide. The performance narrative is really it's the meat of your progress report, and it should include information on grant activities that you've done, progress you've made, what you are planning for the remainder of the budget year through the end of August, and then your plans for Flex grant activities in 2016. This is the narrative opportunity to really describe what your state Flex grant is going to be doing. We definitely want you to clearly and concisely describe your progress on the goals, objectives, and activities that you originally described in your Flex application, and also highlight challenges and changes. My network connection is lost, but hopefully you can still hear me. Can you confirm you can still hear me, Nicole?
We can hear you.
We hear you.
Okay, great. Who needs a screen? Continuing on the performance narrative. So you need to describe what's going on by program area. Of course, the quality improvement and financial and operational improvement were required program areas. The other three were optional or only required as needed, so not every Flex grantee will have activities in all 5 program areas. But describe what's going on by program area, tie this performance narrative to your work plan, and discuss your measures that you originally established in your Flex grant application and what data you have collected on those measures so far. And this is really an opportunity for you to assess your activities, your partner's activities, and collect information from everyone involved in your state Flex grant. Just another reminder, the performance narrative really needs to link with your work plan and your budget, and they should all harmonize and reinforce each other. Some things are obviously going to be repeated, so you can make those ties, but the whole package is an overall story of your Flex grant, and we're looking for things that are easy to understand and make sense, describing what you are doing in the Flex program and what progress you've made. And also can help you, provide more details in certain areas if you're worried about that 15-page limit for the performance narrative. Another important thing in the performance narrative is changes you expect for next year, and challenges and barriers you've faced or have anticipated this year and next year, and how you're going to address them. It's an opportunity to highlight other key features of your Flex program, including lessons learned and best practices, involvement of rural health networks or collaboratives, new and exciting opportunities you see, and please let us know if you have outstanding technical assistance needs, changes to your evaluation plan, or anything else changing in your Flex program. And both the Flex grant guidance from the competitive application and this NCC will be posted on the task website at that link for the Flex grant guidance, so you can make use of them. So now I am going to turn it over to Christy to talk about the program areas and some of the details on the attachments.
everyone. So just as a reminder, all activities must fit within one of the 5 Flex program areas: quality improvement in MBQIP, financial management, population health and EMS integration, CAHs conversion, and integration of innovative care models. If you are uncertain of where or if an activity may fit into a program area, please consult the Flex grant guidance on the task website. For your attachments, please refer to pages 36 through 38 of the NCC Progress Report User Guide for grantees. Each attachment must contain the grant number, project title, organization name, and primary contact name. Please ensure that every page has a header and a footer with each of these items. Your POs would also appreciate page numbers. Grantees are allowed to attach only the components listed within the NCC Progress Report submission. Please ensure that each attachment is correctly labeled and attached in the appropriate section in the appropriate order. If grantees do not comply, the submissions will be returned. Submissions will be returned if they are insufficient or missing information. This is a list of the required attachments. We'll go over them in more detail in a moment. Please note that not all of these may apply to your program, so only the applicable attachments are required. Attachments 1, 2, and 3 are required for everyone. Attachment 1 is the same work plan that was submitted with last year's competing package, including program area, goal, objective, activity, timeline, responsible party, baseline, and outcomes. Correlate to the performance narrative and progress report summary. This should also include updates as necessary to reflect changes and reality. Attachment 2 is your FY16 work plan. It should follow the same format as the FY15 work plan. It should be clear to the reader of the NCC through the performance narrative and progress summary why a grantee has elected to continue specific activities or have adjusted activities as necessary. Please provide a budget justification narrative that is detailed and covers use of federal funds for each object class category. Your grants management officer will review your budget, and they do require that travel and contractual costs be itemized. The narrative should also discuss any significant changes to your FY16 budget relative to your FY15 budget. Flex requires you to budget for at least 1 full-time equivalent. As a reminder, F4HB expects all grantees to participate in the 2017 Flex National Meeting and 1 regional or national meeting each year related to the administration of the Flex grant. The budget should include necessary travel funds. A Flex representative is encouraged to attend the NRHA CAH conference in Kansas City, Missouri. Whenever staff turnover occurs, it's not responsible for executing the duties of the Flex program. The replacement personnel are required to attend a Flex workshop in Duluth, Minnesota within 1 year of their start date. Attachment 4 is position descriptions for all new positions for which grant support is requested. Please indicate if new positions are filled or currently vacant. Position descriptions are required even if the position is currently vacant. Attachment 5 is the curriculum vitae or resume for any staff hired since the submission of the 2015 competing continuation application. As a reminder, performance improvement system PIMS must be reported no later than 60 days after the end of the budget year. That will be fall 2016 for FY15 data and fall 2017 for FY16 data. As we've mentioned in the Flex orientation webinar, we have updated the PIMS measures. So you should go watch that webinar if you haven't already. And we will be sending out more information on PIMS sometime over the summer. Your prior budget period federal financial report must be submitted through the HRSA EHBs no later than January 30th, 2017. The NCC for FY16 will be available sometime in the spring of 2017. Please refer to the NCC Progress Report User Guide for detailed instructions on how to submit this report in EHB. The NCC Progress Report is a great resource for completing your NCC. Other sources of information include your project officer, task, the Flex grant guidance, and the encouraged work plan templates that are available on the task website. Now, I'm going to hand over to Yvonne to talk about MBQIP.
Hey y'all, this is Yvonne. So in terms of Flex participation in MBQIP and what it means for you, as you know, in the latest funding opportunity announcement, FRHP made it MBQIP participation a required condition. And therefore, FORP is maintaining that stance that in order for a CAH to participate in any Flex-funded activities, they must be participating in MBQIP. Hence, this emphasis that FRHP has been releasing resources and information to keep Flex coordinators apprised of what the minimum requirements for MBQIP participation is, which CAHs are at risk, and what paths to take moving forward. The second announcement that we introduced was that there are two minor additions to the MBQIP core measures. For those CAHs not currently reporting on these additional measures, we expect changes related to the planning and implementation of the MBQIP Flex activities to be minimum. And I'll definitely be going over what all of this means in the next few slides. So where are we now? In terms of Flex participation, one of the goals of MBQIP is for 100% CAHs to report on all MBQIP core measures. The overall goal of this is so that there is an improvement in the quality of care. And therefore, this is why this is one of MBQIP's goals. Our current status is that as of 2016, 98% of the 1,300 CAHs have signed memorandums of understanding with FORHP. 96% of those CAHs are reporting data for at least one quarter in at least one domain between second quarter 2014 and second quarter 2015. So major props to all of you because that is huge, and we're really proud of you guys for making such an effort in terms of increasing the participation of MBQIP with your hospitals. And we know this isn't easy, but our data shows that our Flex programs have greatly moved the needle in a positive direction. For example, we've noticed that, for example, in fourth quarter 15 for EDTC, there were 96 new hospitals that reported for this domain. For third quarter 15 outpatient, we had 23 new hospitals reporting for the first time in the outpatient domain. And so great kudos to you. Now the tough part is that there are still a few remaining that we need to bring up to speed. And those only affect 19 states. And in those 19 states, it's only a total of 56 hospitals that have been deemed not reporting or participating in MBQIP. So in terms of reaching the goal of 100% reporting, we have decided to implement a phased approach to provide the most flexibility to critical access hospitals to report on all MBQIP core measures. The criteria for eligibility for flex funds and participation will increase every fiscal year. So this past fiscal year, the capacity building year. It was the time to get all of those MOUs signed. It was the chance to build capacity in terms of understanding the measure, how to report it, and how to look at the data. Therefore, for fiscal year 2016, FORHP has set 2 criteria that all hospitals need to meet in order to receive FY16 funds. The first one is a signed memorandum of understanding with FORHP. The second is that there must be at least some submitted data on MBQIP measures for at least 1 quarter, for at least 1 measure, in at least one of the 4 quality domains within a certain reporting period. In terms of FY 2017, we're still currently working out the details in terms of what those requirements will be, but we definitely encourage you to provide us feedback on what you think that might look like. Now, the criteria that we have set is listed here, and these quarters are based on the latest data that we have available, and it is we chose these reporting periods because it provides the greatest flexibility to include as many CAHs to be participating as possible. And so those typically range from second quarter 14 data to second quarter 15 data. As you know, EDTC data comes in so much quicker, and so we have included up to fourth quarter 15 data because we actually know that that made a difference for a few CAHs in terms of reporting EDTC for the first time. For the outpatient, we only include OP1, 2, 3, and 5 within those reporting periods. 18 are not included because we just added those those measures. OP 20, 21, and 22 are also not included in this year's eligibility requirements because we understand that those are capacity building years. For patient safety, again, to be as inclusive as possible, because we know that inpatient was the first measure to be phased in for MBQIP, we have decided to include inpatient measures as a criteria for being eligible for flex funds. But as you know, because CMS has retired all of the inpatient measures that we selected, those will not be included in next year's flexibility eligibility requirements. And so if your hospital has only been reporting on inpatient, you were probably included, but next year those will not be included unless they are reporting on the other domains. Again, for patient safety, OP27 and IMM2 are not included in this year's eligibility requirements, again, because we understand that this year is a capacity building year. And so there are exceptions to those that were deemed potentially not eligible for flex funds. This slide is only for the hospitals that we have deemed to be not participating in flex. And again, to remind you that there are only 19 states affected by this and 56 hospitals within it. Half of those hospitals were deemed ineligible simply because there was no memorandum of understanding signed. And so we understand that every hospital faces an enormous amount of challenges in terms of reporting. And then therefore we have created a waiver for those 19 states to submit a waiver on behalf of the hospital that has been deemed ineligible of flex funds. And these exceptions apply to hospitals that have been building capacity and assessing readiness for MBQIP for the past year, and are preparing and really committed to starting to submit data in September 2016. And other exceptions are those who just signed the Memorandum of Understanding with FORHP. We understand that even in the past few months, some hospitals have just signed the MOU, so we are allowing you to submit a waiver. Other hospitals have just received CAH designation, and some other hospitals just really do have extenuating circumstances, and we definitely do understand that every hospital is unique. And so that if there are any questions to these exceptions not outlined, please contact your FORHP project officer. And as a note, just to be certain, the hospitals that have been deemed ineligible, your FORHP project officer will be contacting you individually to have this conversation about which hospitals have been deemed ineligible. And so if you haven't received a notification from your project officer, please be patient. We will be starting those conversations in the next week or two. Again, this sample waiver, as I'm going to talk about, is only for those 19 states that are on the list. This waiver is to be submitted as an attachment for with the non-competing continuation application, one of the last attachments. The elements required on the waiver is the hospital name, the reason and situation for not being able to submit data on each domain. We really encourage you to be as specific as possible and to separate everything by each domain. We also encourage you to include any documents that is relevant to your hospital. For example, how to confirm if your hospital's data was submitted and confirmed and accepted by Quality Nets. In terms of there's a sample waiver available on TASC website. That information was already sent out in an email last week. But if you still need a sample waiver or just an idea of what to look for, please refer to the TASC website for that. Now, the next announcement that came from FORHP is the addition of 2 MBQIP required outpatient measures. And the reason we have added 2 additional MBQIP required outpatient measures is purely because of CART technical issues. And the measures are OP4 and OP18. FLEX programs and hospitals will not be penalized for participating in FLEX if data for these 2 metrics are not reported in FY16, which is September 2016 to August 2017. We are allowing this next fiscal year to be capacity building year for these 2 outpatient measures. And by September 2017, hospitals will be required to report on these 2 measures. And the reason we have made this change is we have been hearing from Arquita, our partners, that some hospitals have had their outpatient cases rejected for AMD throughput. And these are rejected because the data elements for OP4 and OP18 were missing. What we did not realize when we set up these MBQIP core measures was that when you submitted OP1, 2, 3, and 5 into Quality Nets, because OP4 was missing, all the cases for OP1, 2, 3, and 5 were rejected. The same thing happened with the ED throughput data set. When hospitals submitted on OP20, those cases were rejected because OP18 was not included. And this only occurs when hospitals have changed their measure preferences on CART to only collect certain measures in a measure set. So if a hospital specifically went into their CART preferences and changed the preference to exclude OP4 and 18. The other cases were rejected in that data set. The assessment from this is that F4HP is not certain how many hospitals have specifically changed their measure preferences in CART. But we expect that it's pretty minimum, that not many have changed their preferences. We have assessed that requiring submission of OP4 and 18 will have limited impact on CAH data collection burden. The additional data elements needed for OP4 and 18 are outlined below. OP4 requires 2 additional data elements, aspirin on arrival and the reason for no aspirin on arrival. OP18 is simply the ED departure date and the ED departure time. For these 2 measures, when you're submitting data for the AMI set and the ED throughput set, no additional cases need to be abstracted. And again, the cases for measures OP1, 2, 3, 5, and 20 will continue to be rejected if OP4 and 18 is not included. What will ultimately happen is that if you are not submitting on OP4 and 18, the hospital will show up on our list of non-submissions. If a hospital ends up as a non-submitter on outpatient data, they might be on a non-submission list, which may possibly affect their eligibility for flex funds. Therefore, these are our list of recommendations. For flex coordinators, we ask that you add these 2 measures to your non-competing continuation application work plan. We encourage you to update documentation and any list of required MBQIP measures to include OP4 and OP18. We request that you inform all of your hospitals of the inclusion of these 2 additional measures as required MBQIP measures. Hospitals are encouraged not to adjust the measure setting preferences on CART after downloading the latest version. The latest version of CART is available or should be available on April 2016, so next month or next few weeks. And this is for submitting data on Q4 of 2015. And so, as you also may know, there was the outpatient data submission deadline for Q4 2015 is due June 1st, 2016, not May 2016. Currently, we are not aware of hospitals using vendor tools to submit data and having those cases rejected. But if you do know hospitals that use vendors, please let us know and we can investigate further. TASC and Arcata have already updated all the documents relevant to these 2 changes. If you have any questions related to measure submission process, please feel free to reach out to task@ruralcenter.org. And if you have any questions or comments related to this policy change, please reach out to mbqip@hrsa.gov. Thank you.
And back to Sarah. Here's a couple of more reminders about EHB. The EHB system does time out after 30 minutes of inactivity, and it considers frantically typing in a text box to be inactivity. So be sure that you save your work at frequent intervals, and otherwise use that save button on your various EHB pages so it reloads the page and resets your timer. As always, for assistance with the EHB, contact the HRSA call center, which is available by phone 8 a.m. to 8 p.m. and has the web interface that you can use to send emails anytime. for those of you with quarterly reporting requirements on your current Flex Award, those quarterly reports are still due this month. And please do read the NCC a couple of times. Does it make sense to you? Is there enough detail? Do you have questions? We really appreciate your feedback. And let me rephrase it. Read your submissions before you send them in, and make sure it all makes sense, especially the people who are less familiar with your Flex program than you might be. On the second issue, if you have questions about the NCC guidance that is posted in EHB and on the TESC website, let us know. We do appreciate your feedback about how we can make this better. And we will be returning NCCs that have been submitted if it lacks detail or omits required information. And please feel free to reach out to your project officer before you submit the NCC as well. We are glad to talk to you about what information needs to be included and how you can better it.
Sarah?
Yes.
Hi, this is Debbie in Alabama. I'm a little confused about something, and I'm not clinical, so it may be something I'm not seeing. But on slide 30, you're saying OP4 and OP18 are required, but hospitals won't be penalized if they don't report prior to August 2017.
Let me
pardon?
Continue.
Mm-hmm. But then slide 33, is that the one? 32 says cases for measures will be rejected if OP4 and OP18 are not included, and that would lead to flex ineligibility.
It will not lead to automatic eligibility. You are correct. If hospitals are not submitting on OP4 and 18, all cases for OP1 through 5 and ED throughput, which is OP18 and 20, will continue to be rejected. And so even though we have provided this upcoming fiscal year as capacity building year, we strongly encourage hospitals to include OP4 and 18 now. Did that help answer your question? And we realize that, yes, it is 2 additional measures that we have included. It will have a limited impact on hospitals. OP4 and OP18 only have 2 additional data elements in each one. And so it's the elements needed are pretty standard in terms of ED departure time, aspirin arrival, if it was given or not. And so we imagine that most hospitals are already collecting these sort of data elements, maybe not submitting it.
But if it's not submitted, it will reject the other measures, and
Correct.
Then they'll be on that non-submission list.
Correct, for outpatient. So we, FOHP receives several non-submission lists, one for EDTC, one for HCAPS, one for inpatient, and one for outpatient. A hospital will non-submission as a non-submitter on the outpatient measure set. But because our requirements, or at least for this year, are broad, they just because a hospital is included in the non-submission list for the outpatient, they may already be submitting on the other domains, such as HCAPS or EDPC. So we at FRHP haven't determined what the eligibility requirements are for FY17, but that information should come out in September of 2016 so that flex coordinators will have as much time as possible to plan ahead.
Yvonne, this is Sarah. I would just add to that there are 2 additional outpatient measures, OP22 and OP27, that are not affected by that requirement because they're not chart abstracted. So if hospitals are reporting on either of those 2 measures, they wouldn't appear on the non-compliant list for outpatient because they're submitting for those.
Correct. Thank you, Sarah.
Now I'll go back through some of the questions that have been entered in the chat box, and we'll see about answering these. Catherine Miller asked about the header and footer, and I believe Kevin already typed in an answer in the chat box. The full details should be included on the first page of every attachment, including grant number, name, state, everything else that was on that slide. And then you can just have abbreviated page numbers and state information on subsequent pages. But we really do appreciate having at least your state and your page number to the attachments. It helps us keep them straight. Kenny asked, do we attach indirect cost agreements to the budget narrative? Kenny, no, you don't need to attach indirect cost agreement unless it has changed from your last grant award. Most of them do not change, and the previous one remains in effect. Oh, Kevin, I contradicted Kevin. Sorry about that. Please do include your indirect as an attachment if you need to. And of course, the amount that's budgeted for your indirect costs should be listed on your budget narrative so it's clear where the total amount of grant expenses are going. Judy asked, can we use an alternate work plan format rather than the suggested one on the task website as long as we include all the required elements? And that is up to you, Judy. We do encourage using the provided work plan template, but it isn't mandatory as long as your work plan meets all of the required information. Stephanie asked if we are asking for new MOUs for every facility or if the current MOUs are continuing to be recognized by FORP. And as long as you have an in-place MOU with those critical access hospitals, they remain in place. You don't need to get a new one. If you have questions about any specific hospital, whether they have an MOU on file, just reach out to your PO and ask about them. We can confirm that for you pretty easily. As Catherine asked, if you are in one of the 19 states that has a CAH on the ineligible because of non-submission of MBQIP data list, you'll be contacted by your project officer with the exact names and CCN numbers of those critical access hospitals, and we'll be getting that information to you within the next week or so. Stephanie asked a complicated question about intelligent reports. When the reports display NA and a CAH has attempted to report but has no cases, are these CAHs going to have to submit documentation that they didn't have patients that met the criteria in order to receive a waiver of the MBQIP requirement?
In terms of documentation, in terms of the fact that simply we do understand that not all patients that you encounter meet the criteria for submitting data through QualityNet. I think in the waiver, if your hospital is on that list, there is an other section for you to list out other reasons and situations that your hospital might face. And one of those is, what if none of my patients meet the criteria to upload, to submit on QualityNet? And so simply letting us know that that has happened without any attached to it is recommended. The more detail you can provide on these waivers, the more we can work with you and understand your situation. And so we're definitely, we definitely want all hospitals to be reporting. And this waiver is to show that there is continued commitment towards MBQIP. And that there is a commitment to submitting data. And so if that is displayed or communicated on the waiver, you know, that's really what we're looking for. In general, we set these minimum requirements to to encourage hospitals to report and improve the quality of care they deliver to their patients. This isn't really like, you know, to ding people and to kick people out. We really want to include everyone and really strive towards the goal of improving the quality of care in rural hospitals.
Nicole, I got disconnected and had to reconnect to the webinar, so could you forward the slides to the last slide with the question on it? Continuing with the chat box information, Matt asked about the due dates for quarterly reports. And yes, Matt, they are due by the March 30th in EHB, so that is next week. Stephanie asks, for HCAHPS, about those that show up on as NA on the Telegen reports because they haven't met the number of surveys threshold for quality repair, are they going to have to request a waiver as well?
Yes, if a flex coordinator is able to get kind of a tracking sheet of hospitals that are working towards HCAHPS, for example, they just submitted data in the first quarter, and you know they submitted however many surveys. If some sort of documentation can show that they have just started submitting on HCAHPS data, that is acceptable. We also know that there is probably a QualityNet report that can be generated to display that. Or in general, the HCAHPS reports should display a footer note, and each footer note explains why an NA has been displayed. Sometimes it is because there was insufficient data on some missing quarters or months, and so any documentation from these reports that could be generated on Hospital Compare QualityNet is acceptable. In general, the more information, the better.
Hi, Katie. I'm not sure what your question about ID agreements is, although it looks like you and Mike, oh, indirect cost agreements. You and Mike were chatting about indirect cost agreements. Many states and other grantees do negotiate indirect cost agreements that are federal indirect costs that are fixed for a period of time, commonly 4 years. But it does vary, and different states have different processes. Again, include the amount of money that's going to be charged to your flex grant in the FY16 budget, and if it requires explanation or justification in the budget justification, please include that information. That is all the questions in the chat box. Are there any more on the phone lines? And as a reminder, I think most lines were muted by default, so you might need to press *2 if you're trying to talk and we aren't hearing you.
Sarah, this is Scott. I have a quick question. I haven't seen anywhere is max number of pages for the entire grant.
Hi, Scott. Your sound was a little off. The max number of what?
Is there a maximum number of pages for the entire grant?
A maximum number of pages for the entire NCC? No, there isn't. The only section that actually has a specific page limit is the 15 pages for the performance narrative. But we expect that most of the rest of the attachments aren't going to be hugely voluminous. This should be smaller and shorter than your full grant application last year. Again, this is a non-competing continuation. It's a project update. It's supposed to be easier. Any other questions? Tracy is typing a good reminder in the chat box that as well as contacting your project officer with questions about the NCC, please do use TASK. They're your technical assistance provider and can help you with structuring your NCC report, with making plans for changes and adjustments to your flex activities that you may want to make next year, and the whole other range of task assistance. Ask them to review a portion of your NCC if you have questions or would like some feedback. Do give them a few days notice that that's what you're doing, and don't expect an instant turnaround, because as good as Tracy and Nicole are, they aren't superwomen either, except possibly on Thursdays.
This is Gina in Montana. I have a question going back to the MBQIP reporting.
Go ahead, Gina.
Hi. I'm just curious, in the different domains, the reporting periods that are required so that it shows that facilities are submitting data. I don't know what facilities might be at risk in our state at this point, but I know that we do have 2 facilities that had not been able to report during these time frames on outpatient and care transition data, but we have since been able to work with them to get them to the point where they're now able to report. So my guess is that they would show up as non-submission for these time frames, but they have been submitting, and they did submit in this recent reporting period, but it falls outside of, it's actually within this grant year, which was what I thought they needed to do, but it doesn't fall within these guidelines. So I'm hoping that they would have reported HCAP so that they are not showing up on the non-submission list, but I guess I'm just curious why, if this grant year was the year for required participation, we're not looking at any reporting in that period for being included in the grant in the future.
So is your question if that CAHs that just started reporting, can get a waiver? The answer is yes. That's a easy waiver. You provide evidence that they started reporting in January 2016 and they're now reporting. If they're even on the non-submission list, as you say, they may not be. The bigger policy question about what quarters of data we're using to come up with that, identify the cause on that non-submission list, I will hand you over to Yvonne to speak to.
Hi. So the quarters we have chosen go back to 2014 in second quarter and go up to second quarter inpatient and outpatient and fourth quarter 15 for EDTC. So second quarter 15 is the most recent recent data available that we have on file. And so that's why we chose those reporting periods. We did look at third quarter 15 data for inpatient and outpatient, and we did see that it did make a difference for 2 hospitals. And we did note it in our list, and I do believe Montana was, or at least Montana, one of your hospitals reported for the first time ever, and so we definitely included that. In terms of the waiver is simply a way to show that there is continued commitment on the hospital side, even if it is capacity building. As you know, only 56 hospitals are on our list out of 1,300 hospitals. And half of those, the 56, are simply because no MOU is even signed. And so for the other 26 hospitals that were deemed ineligible because of non-reporting, that is, the waiver is their chance to explain their circumstances. And I think that through continued conversation with the project officer, I think it's clear to us that we know that every hospital is making the greatest effort to report. And this is why we are allowing the submission of a waiver. And so the FOHP will be reviewing every waiver and working again with the flex coordinators affected to see if those waivers are accepted or not. So we definitely encourage you to send us the drafts, and so that when through in the NCC, it will be a smooth process. There will be continued communication between the flex coordinators and the project officer.
Thank you.
And this is Sarah again, just along those lines, Gina and Stephanie. I wanted to share last week when I was out in Spokane at the Northwest Rural Health Conference, I heard a lot about the challenges that some of your colleagues out there in Washington and Idaho in the region are having with the PQRS reporting requirements for their employed physicians. And, part of that is because those requirements came on really fast and they didn't have a chance to learn the process very smoothly. So that's why we're starting with a minimal bar for MBQIP. Report data once in the year in the reporting period that we have data available from, or provide justification for a waiver. And then we're all learning, both FORP and the flex coordinators and the hospital staff, how to carry out these quality reporting processes and practices and how to get better. So for some of these calls, you will be able to write a very easy waiver as a flex coordinator, and you may not even have to go to them for more information if you can document that they started reporting in January or February. Done. Move on. Let's see. One more question in the chat box. Lisa asked that 3 of the Georgia hospitals on the MBQIP non-submitter list have submitted HCAHPS data for the fourth quarter of 2015 and fourth quarter of 2014 and first quarter of 2015. How do we assess this contradiction in information? And again, if If there's information discrepancies, please submit that data report to your project officer with a waiver request. As Yvonne said, we're glad to look at a draft, and maybe we can answer the question even before you turn in your NCC. Thank you for asking the question, Lisa. Any other questions out there?